Dear audience, let me present you my PhD topic, which is about the applications of dietary fibers in patients with metabolic disorders. My name is Evelin Juhász and I'm a dietitian, and my vision is to normalize the metabolic disorders of the patients by receiving dietary fiber instead of medication, and my mission is to draw attention of the physicians to the results of the studies regarding the management of polycystic ovary syndrome. In the past 2 years, we worked on 2 network meta-analyses, and based on their results, we would like to perform a randomized controlled trial. The first project title is "The galactomannans are the most effective soluble dietary fibers in type 2 diabetes." Just a short background of this topic: 6.28% of the world's population has type 2 diabetes, which is a quite high number, and according to the literature is still increasing. And previous studies shows that dietary fibers have a potential to reduce cardiovascular disease and normalized hyperglycemia in patients with diabetes. But what are these fibers? Fibers means carbohydrate polymers with 3 or more monomeric units, which are neither digested or absorbed in the human small intestine. And traditionally, these dietary fibers are classified as soluble and non-soluble according to their solubility in water. They have more beneficial effects on the human body. For example, they can stimulate the secretion of gastric juice, they can resist the digestion and absorption, and regulate the gut microbiome. And I would like to highlight that using these fibers is a gap in the guidelines of diabetes. That's why our aim was to investigate the effects of dietary fiber supplementation on glycemic control and lipid profile in patients with type 2 diabetes. Our clinical question was, does dietary fiber intake decrease the hemoglobin 1c level compared to another type of dietary fiber or no dietary fiber intake? The population was patients with type 2 diabetes. The intervention and comparators were the same, soluble and non-soluble dietary fiber and no fiber, and the outcomes were the glycemic and the lipid factors. Our hypothesis was that soluble dietary fiber intake can normalize glucose and lipid levels in patients with type 2 diabetes. We did a systematic search on 3 databases with the following search key. At the end of the selection process, we could include 56 eligible articles. Now I'm presenting only the main outcome in detail, and the other outcomes results will be in a summary table due to the time limit. So on the A graph, you can see a network regarding to each interventions. And the size of the nodes is proportional to the number of the studies evaluating each intervention, and the thickness of the edges is proportional to the number of each direct comparisons. On the B graph, you can see the Sukra curves. The surface under the cumulative ranking curve is a numeric presentation of the overall ranking and represents a single number associated with each intervention's Sukra values, which are ranged from 0 to 100%. So it means that the higher the Sukra value and closer to 100%, that intervention has the probability to be the most effective one. And on the C graph, you can see the rankogram, which represent the Sukra values. And based on these Sukra values, at this outcome, the galactomannan dietary fibers seem to be the most effective intervention. And as I said, this is a summary table of the results. Here you can see the different types of dietary fibers and the 9 outcomes. And based on the Sukra values, the beta-glucan, the galactomannan, the gamma-arabic, the psyllium, the resistant starch, and the psyllo-oligosaccharides were the most effective interventions for these outcomes. As a conclusion, I can say that the galactomannan was the most beneficial intervention for 4 outcomes from the 9, and it has more significant results compared to no fiber. Our study strengthens that, to our knowledge, this is the first network meta-analysis assessing the effects of soluble dietary fibers. It has a rigorous methodology, and we could include 16 types of dietary fibers and almost 3,000 patients. As of course, we have limitations, the small number of the direct comparisons, the different doses and formulations of the dietary fibers, and patients had various background diets, medications, and lifestyles. Our findings have a public health implication in terms of using dietary fiber as a supplement besides the medical therapy for managing type 2 diabetes. And for the future, I suggest further long-term randomized controlled trials. And effects of these dietary fibers should be assessed on other types of disease, which include metabolic disorders, for example, PCOS. Our manuscript was published in the American Journal of Clinical Nutrition journal. And the second project title is that the DASH diet is the most effective dietary intervention in women with PCOS. Just a short background of this topic. PCOS is one of the most common abnormalities in women of reproductive age, and as a first-line approaches in the management, dietary, exercise, and behavior therapies are included. But for the assessment and management, there is no or limited evidence about the specific dietary composition. That's why our aim was to identify the most effective dietary approach in the treatment of PCOS. Our clinical question was, which dietary approach has the highest effect on normalizing metabolic and hormonal measures in women with PCOS? The population was women with PCOS. The intervention and comparators were the different types of dietary interventions, and we included the gold standard medication, the metformin. And the outcomes were the anthropometric, metabolic, and hormonal measures. Our hypothesis was that dietary approaches can normalize metabolic and hormonal parameters in patients with PCOS. We did a systematic search of 5 databases, and at the end of the selection process, we could include 23 eligible articles. Again, just presenting a summary table of the results because we have a lot of. On the left side, you can see the different types of dietary interventions and the metformin and the 10 outcomes. And based on the sucra values results, the DASH diet, the low-calorie, the low-carb diet, the low-calorie diet with metformin, and the metformin alone, and one outcome, the most effective intervention was when the patients hadn't got any different types of dietary intervention, just the normal diet. As a conclusion, I can say that DASH diet was the most beneficial intervention for 4 outcomes, and it has more significant results. We had a rigorous methodology, and most of the relevant parameters are included in this study. And the small number of the direct comparisons and the low number of the patients and various age and ethnicity are the main limitations of this study. Our data provides a basis for dietary intervention recommendations for women with PCOS. And I would like to mention that reducing the daily amount of calories and the changing the quality of food, like in the DASH diet, is more effective than those diets which change the macronutrients ratio. For example, the high protein diet or the low fat or the low carbohydrate diets. And for this implication for research, a larger number of RCTs are needed with a longer follow-up time. This manuscript is under revision at the Reproductive Biology and Endocrinology Journal. And our third project, which is the protocol for a randomized controlled trial. Just a short background of this topic. Our first network meta-analysis proved that dietary fibers can normalize glucose level. Our second network meta-analysis showed that a well-chosen diet can be effective in treating PCOS. And considering the metformin side effects, we would like to suggest these women an alternative therapy. That's why our aim is to examine the effects of dietary fiber in the treatment of PCOS. This is the protocol drafting. We would include women with PCOS, and after the randomization, we would get them dietary fiber and placebo, which would be the maltodextrin. And after the follow-up measures, we would like to analyze the menstrual cycle, glycemic factors, lipid factors, hormonal parameters, and the non-alcoholic fatty liver disease. As a summary, I would like to show you again the 3 projects what we are working on. And to be honest, the last 2 years was very active for me. I had more presentation, a poster presentation or oral presentation at conferences, and I started to working at the Department of Dietetics and Nutrition Sciences, and I'm lucky to work with the Hungarian Dietetic Association on projects.
my main issue, and I know that you are the time limit, but you missed the results of the second project. You just said that, and you just mentioned it in a few words and then went to implications, right? So I presume it's a very complicated result background you have there with the second project, right?
Yes, it's basically the same as in the first project. So each outcome has a network, a Sukra table, a rankogram, which can be presented here because it's too much.
Yeah, I understand. There's one thing I didn't understand. It's not really a statistical thing. It's just something I wondered about. That when you're looking at dietary fibers, I presume that there is some kind of gut microbiome digestion, right? So it's not going through completely untouched through your tract. So did you guys consider the gut digestion effect? I know that inulin and a lot of others are important in this aspect. Was that considered when you were planning to structure your data, or you didn't consider it at all?
That's a good question. In our study, we just focused on these outcomes, the glycemic and the lipid parameters. But it's worth to mention that these dietary fibers have different effects. For example, in the gut microbiome, some of them can be fermented or the viscosity. So maybe in the future it can be considered to making a...
And I didn't really understand what the outcomes were and what scale you were measuring these outcomes on the first project. Can you go back to that Sukra? And again, I have to commend you that you explained what Sukra is. That's actually...
We collected the mean difference changes from the articles. So
what mean difference change of what?
Of the different... the hemoglobin A1C level, the fasting blood glucose level. They check the average fasting blood glucose level and the
Okay.
When they start the trial and the end of the...
And the Sukra figure that you're showing is for one of these outcomes, right?
Yeah, it just one for the hemoglobin A1C level.
Okay. And one more thing with the the study you're designing, did you guys consult with the statisticians, and did you make sample size calculations?
Not yet. In the future we will.
It will be critical for you in this study, I think.
I also have a question to your third project, the trial. So you have two groups, but there is an intervention in both groups. Don't you want a control group, a third arm?
This will be the control group because maltodextrin is not a dietary fiber. It will be just a placebo. Take down these pills.
So maltodextrin doesn't have any effect?
Based on the previous studies, there isn't any, because in the first network meta-analysis, most of the RCTs used maltodextrin as a placebo with the dietary fibers.
So if you haven't done your sample size calculation yet, right? Yeah. And you are pretty at the beginning of the designing of this trial, so just give it a thought, because you may miss a signal, an effect size of the finding if you compare it to nothing as you compare it to maltodextrin.
Okay, thank you.
Because there must be something in it, it has a name, dextrin, so to me it suggests it's a dextran. So, okay, that's it. But
thank you, we will consider it.
Can you tell me what's a DASH diet is?
Yeah, that diet means that dietary approach to stop hypertension.
Yes.
So it's the whole goal to reduce the high blood pressure in patients.
What do you have in this diet?
Comparing with the Hungarian typical diet, it has more vegetables and fruits in it, and oilseeds, for example, and fish meat and poultry, and rich in magnesium and sodium. So I think it's much different than the typical Hungarian diet.
Okay, thanks. And the other, do you know some literature about dietary fibers and inositol in combination?
Not yet. I haven't seen any articles. At the beginning of this year, we thought that it would worth it if we compare the inositol with dietary fiber.
Yes,
Maybe
would be
it works with Dorina's project. So in the future, maybe.
Thank you very much.
You mentioned that one of the strengths of these studies were the rigorous methodology. What was the patient compliance during this study?
The follow-up time was from 3 to 6 months. So I think they could make it easy. And they got these dietary fibers as a supplementation besides their medications like metformin. So there weren't too much excluded in the articles.
Studies with any kind of dietary intervention are really difficult. I don't know how much are you familiar with the EFFORTS trial, which is it's about the reduction of fat content in the diet of recurrent acute pancreatitis patients. So we struggled a lot of the issues, and the lessons what I have learned from that one is that we have to take in consideration when we design a study like this that the repeated kind of meeting with the patients, that it's, meeting with someone and just talking to them, it can affect on everything, and especially on the diet. And the question with this study design, it's just will you give a kind of a basic dietary intervention, and will it be the same on the arms, and how will you follow up regarding to that they are adherence with the regular dietary requirements for type 2 diabetes?
Yes, I totally agree with you. We have to follow up their daily diets. And we are planning to make consultations with them, for example, in online or in the real life, and give them a dietary intervention at the beginning of the study, and follow up them. I think in every month would be a good solution for this, and making diet documentations. They have to
food log.
Yes, for example, in a mobile application, or they can write it.
And this is something as why you should consider Professor Molnar's advice with the other arm, where you don't give anything extra, just the basic dietary intervention and the follow-up. Just think about it. And what's the difference between the Mediterranean diet and the DASH diet?
The Mediterranean diet focuses on the olive oils and the oilseed mold than in the DASH diet. So in the Mediterranean diet, they suggest just only use olive oils, for example, in cooking, and in the DASH diet, we can use more oils. That's the main difference, I think, but they're very similar to each other.
And one more question, according to your meta, so the patients in these studies, do they take any kind of oral anti-diabetics?
In the first project, yes. Most of them, they got.
And it was the same treatment time where they were involved in this kind of dietary interventional trial?
Not really. This is a big limitation in our study, that their medications and the various backgrounds of, for example, at the time, the medications, yes, they were very, very different.
Are you familiar with any kind of interaction between the oral anti-diabetics and the fiber, which we are offering for this patient?
In Hungary?
No, I mean as the so the metabolism of the oral antidiabetics, it's the same with and without fibers.
To be honest, I don't know the real metabolism of these medications, but I think they haven't got any effects on the medications. Usually, these patients get this dietary fiber before the breakfast, and I think using these medications is a good way to take after the breakfast. So maybe there is some time between the two.
A big breakfast.
Yeah, sure.
Okay, and you've mentioned the sentence. It was in the I can't remember in which slide, but you said that more significant result. What do you mean by that?
Yes. For example, the DASH diet compared with the normal diet has more significant results. It means that it was significantly better than the normal diet. And in the first network is the same, that the galactomannan had more significant results, in these little stars mean that, compared to no fiber. They were significantly better.
Okay, and I ask Peter to make the correction with this wording.
The problem is with more. It's either significant or not. Okay, you can't say more significant.
Okay, just really the more.
Yeah, but now that I got the mic back, let me. Can you go back to that design slide that you had, the RCT design slide? I just realized what's bothering me here. So today we've learned that BMI is a big problem in PCOS women, right?
Yeah.
In an RCT, you have two ways of handling this. Either you consider that at the randomization stage, or you have a lot of patients and then you consider it at the analysis stage. Okay. Were you planning to add some kind of a layered randomization here?
We are planning to include just these women who has higher BMI than 25, for example. So not after the randomization.
Okay, so you are controlling for BMI.
Yes, because previous studies show that this has a bigger effects on obese patients than in the lean PCOS patients.
So you're hunting for effect then.
No.
Okay, this is something that you need to really consider from the questions point of view, what your exact questions. And this is just something I was wondering, in your field, is it normal that you only add something and you're not monitoring other intakes of patients? So in this case, you say that you have dietary fiber supplementation, right? But they're eating other things, the patients. Are you monitoring what they're eating?
Yes, we would like to with these follow-up visits and they dietary documentation, which can be in a.
And are you controlling that?
At the beginning of the study, they will get a dietary intervention suggestions. Try to keep these facts, which include that dietary intervention, and of course there will be some limitations on these diets.
Okay.
Primary outcome is normalization of the menstrual cycle. That is, to me, far too ambitious. So I can't believe that just taking a question mark gram dietary fiber a day could have such a profound effect of normalization of menstrual cycle. So there are a lot of confounding factors here, and you will either end up with an enormous sample size, or I can guarantee the non-significant result, or the study will be underpowered. You need very strict dietary control, but I mean, you can copy other large studies. There are several RCTs in this field, so you can follow their protocol. This is not my area of expertise, but you can possibly choose but then the whole study doesn't make sense. So to choose another primary outcome, but then what is related to dietary fibers, but yeah, I don't know. I have a lot of concerns with that idea. So I would really give it another thought.
Thank you.